Okay, so good afternoon. My name's Dominic. I'm one of the consultant gastroenterologists. I've been in place at Barnsley for the last couple of years now. And it's fallen to me to talk to you about the process of diagnosing irritable bowel syndrome. And you may ask, is this an important part of the life of a GP? Well, this is quite an interesting slide. I don't know if you can all see it properly, but it's an aggregation of lots of data sources. And they're looking at the prevalence of certain gastrointestinal disorders and pathologies. They're looking at the number of incident cases on a national level. And then they're dividing those incident cases by the number of CCGs, which they thought to be 221. And they assumed that each CCG was approximately looking after about 200,000 people. So they reckon that for a single GP in his or her practice, for instance, they'd be seeing a case of Crohn's disease every 4 to 7 years, say someone with ulcerative colitis every 2 to 4 years. And yet if we go all the way to the other sort of side of the spectrum, if you look at irritable bowel syndrome, you'll be finding a de novo presentation of irritable bowel syndrome at least 4 times a year. They've quoted the prevalence at 10.5%. And if you compare that to the prevalence of type 2 diabetes, which they reckon was 4.5% in 2011, it's twice as common. In secondary care, functional gastrointestinal disorders account for at least 20-25% of our work. So these are common pathologies that we see. So what I'd like to do is introduce a clinical case to you. So this is a 27-year-old female, and she was referred from primary care to the surgeons in 2014. And she presented with right-sided abdominal pain, weight loss, and loose stools. So we've got, a snapshot of her clinical presentation. What do we do with that information? What do we gain from our clinical histories? What do we tease out from the dialogue from the patient? What's important, what's not important? So I'm going to ask you a question. What symptoms or biochemistry would give you concern? So the first is nocturnal pain. The second is diarrhea. The third one is bloating. D is weight loss. And E is iron deficiency. So, okay, we all done? So half of you have got the right answer. So the answer is indeed weight loss. And I'll just take you through them. Nocturnal pain, that's slightly mischievous, of me to put that in. Nocturnal pain is absolutely no discriminatory power between differentiating between organic and inorganic presentations. If I was to say nocturnal diarrhea, then absolutely someone who's got acute severe colitis, an inflammatory bowel condition, they're going to be going to get up in the middle of the night regardless of whether they're lacking in sleep or whatever. Diarrhea, well, everyone gets diarrhea. You don't necessarily have to have a GI disorder. And bloating, what do we think about bloating? Well, it's a part of the spectrum of the functional gastrointestinal disorders. It fits with lots of kind of competing diagnoses, but it's pretty much about that discussion we briefly had about iron deficiency. You don't just look at someone with iron deficiency and say, well, I'm going to possibly monitor it and repeat the blood tests in 3 months' time or something. You have to see what the clinical context is, how the patient is, if you've got any concerns about the patient. So if you had a young patient who had a uncomplicated presentation with no features of concern, then absolutely bloating is something that you'd expect as part of a spectrum of functional gastrointestinal disorders. However, if this was someone who was 50, who was a lady, who suddenly presented with abdominal distension and bloating, you'd be thinking about other pathologies, and probably you'd be requesting your CA125s and your ovarian ultrasound scans at this point. And as we mentioned, iron deficiency is nothing more than an opportunity to explore the history a little bit better with regards to their diet and their menstrual cycle. So what am I alluding to? Well, of course I'm alluding to red flag symptoms. So these are the nice red flag symptoms. These were produced in 2008. There are various other international and national bodies that also produce their own kind of collection. But essentially it's, does your patient have unexplained weight loss, rectal bleeding, is there a family history of colorectal cancer, or is there a change in bowel habits? And what they reckon was, is there a change in bowel habit for anyone over 60 with a persistence of an abnormal bowel habit for more than 6 weeks? And again, this comes back to, just the idea that, you've just got to see how your patient is before you. Certainly if someone were to present with a hyperacute presentation of change in bowel habit that was spontaneous and self-limiting, then obviously we'd be thinking about infectious etiologies. In terms of examination, obviously if you start feeling masses, either on your abdominal examination or on your digital rectal examination, that requires further follow-up. And in your biochemical analysis, anyone with iron deficiency anemia or the suggestion of raised inflammatory markers should warrant a referral to secondary care. So, going back to my patient, the patient was seen by the surgeons. The surgeons are very keen on their investigations. So the patient was immediately presented to the endoscopy department. And we've got some nice pictures here. So this is the ileocecal valve. So this is at the junction between the large bowel and the small bowel. This looks, pretty healthy. This is sort of just coming a little bit further back into the ascending colon. There was this area in the sigmoid colon. This is about 25 centimetres from the point of insertion. So it's not really projected very well on here, but what you can see is this faint blush of erythema, and there's this sort of punctate, sort of hemorrhagic appearance, just around here. The endoscopist, obviously noted that fact. I wasn't entirely sure what the clinical significance of it was either. And what we see here is this is a retroflex view, so we're now in the rectum, and we've turned the camera upside down. So essentially we're looking for perianal or distal rectal disease. And again, there's possibly a suggestion of a little bit of redness just around here, but we were kind of really struggling a little bit to find any objective pathology here. So, it was actually formally reported as normal apart from that area in the sigmoid colon. But anyone who has a change in bowel habits or come in with diarrhoea, we automatically do serial biopsies. And the reason for that is even if the bowel looks entirely normal, we want to exclude things like microscopic colitis. So, interestingly, when the report came back from the histopathologist, they found that there were some areas of inflammation in the cecum. They described this as focal active cryptitis, and there was also some mild inflammatory change in the rectum. However, the reporting histopathologist didn't feel that this was consistent with inflammatory bowel disease. Sort of slightly paradoxically, we then went from being an entirely invasive in the investigation all the way to small bowel studies and finally a calprotectin. So, and the calprotectin was completely normal, or it depends on your reference values, but anything certainly around that level I wouldn't be too concerned about. So, when the surgeons see their patients, when there's nothing definitively surgical about the patient, and when you have a persistence of symptoms, at some point the friendly gastroenterologists get involved. So, this patient was seen by one of my colleagues, one of my senior gastroenterology consultants who's now moved on to a different trust. And he acknowledged that this patient had long-standing diarrhoea. The patient's been seen previously and investigated by another trust. I always think that's a little bit weird when patients are sort of fairly peripatetic in how they consume their sort of healthcare resources. The patient was opening bowels 12 times a day and was getting rectal bleeding and associated fecal urgency. On examination, nothing really exciting apart from just mild or minimal right iliac fossa tenderness. In the course of her management, she was subsequently seen by the IBD nurse specialists, and the patient was still very, very symptomatic, although her bowel frequency had improved a little bit. And she was passing a lot of blood, but it was particularly noticed when she was wiping herself with toilet paper. And at this point, her mesavant was increased to 4.8 grams. And so I think we've missed a slide somewhere. So one of the slides is missing. So based on this information in seeing the gastroenterologist, the combination of persistent diarrhea, some inflammatory change noted on the biopsies, and also this kind of focal area of erythema that was noted during the actual colonoscopy itself, a confident diagnosis of ulcerative colitis was made. And therefore, simple first-line agents were started for a diagnosis of ulcerative colitis, so that was Mesavant. She was also given topical treatment and then referred to the National Crohn's and Colitis UK website. So after that, she was still symptomatic. She went to see the IBD nurse specialist. Her Mesavant was increased from the maintenance dose of 2.4 grams up to 4.8 grams. Yet there seemed to be very little in terms of her, improved response to this increased dose of 5 ASAs. So it was at this point that she was referred to my clinic. And I think that whenever you've got a patient who's behaving atypically, who is not responding to conventional medication, who there's an incongruity between what you see on the endoscopy and what you see on the histopathology, it's always really, really important just to get back to basic principles in medicine, and that would be taking really good, robust history. And the other thing to say is that it's also, a fairly useful trick to just try and dismiss anything that anyone said before and approach a patient with a completely new, fresh set of eyes. So this was my history from this lady. She was opening her bowels 7 times a day. This was a loose or liquid stool. She was also passing this kind of very clear mucoid type, discharge rectally. And that's quite a common thing, and it can be seen in inflammatory bowel disease. It can be seen in irritable bowel syndrome. It can also be seen if you've got a big rectal villus adenoma, which just secretes these, this mucus. She was noticing bright red fresh blood on wiping herself. So this is just anorectal bleeding. She's not passing big thick clots of blood or anything like that. And I'd suggest to you that if someone's opening their bowels 7 times a day, at some point you're going to get a slight little mucosal tear, or maybe a hemorrhoid starts to develop. And what we do know is she's already had her colonoscopy, she's had retroflex views. We know that there's nothing around that sort of anal canal or in that distal rectum suggesting anything more sinister. The other thing to say is that she was experiencing intense generalised cramping abdominal pain, and that this pain was relieved with defecation. There were no nocturnal symptoms, and as I suggested to you, if you've got colitis or Crohn's colitis or ulcerative colitis, you are going to be up all night if you've got a flare of disease. And she also was losing weight, and you kind of feel, well, obviously that's an organic problem. But when I asked her, what her appetite was like, she said it was suppressed. And it's quite easy just to take that at face value, but I wasn't that happy with her answer. So when I questioned her a little bit more, this is a lady who still hungry. She doesn't have any sort of abnormal sort of ideas about food. It's just that as soon as she started eating certain food types, she became intensely afflicted by her symptoms. Other things of note: she was getting bore gimme, so lots of rumbling in her tummy. She was dizzy, she was fatigued, she was generally irritable, she had a labile mood. She wasn't sleeping well. She found it very difficult to get to sleep. She was waking through the night. She felt absolutely exhausted during the daytime. I quizzed her about, whether she actually felt whether she was formally depressed. At this point, she became very sort of tearful. And those parts of her history are always quite difficult. You have to tread fairly lightly. But just the response you get from your patients can give you some sort of idea about whether there are, sort of psychogenic sort of qualities to the presentation. And then when I started talking about her past medical history, she had a confirmed Campylobacter infection in 2015. She'd been working as a nurse in a different hospital. Recently had a baby girl. I'm not sure whether there was some sort of tension between herself and her partner. And what was very noticeable is that stress, changes in her diet, these are the things that were driving her symptoms rather than anything else. So my history seems to be a little bit different from the histories that were taken before me. And certainly I felt at this point there was a very, very functional flavour was coming through from this young lady. And, we have to start thinking about, is this a functional gastrointestinal disorder? And when we start thinking about such things, we need to know how to classify functional gastrointestinal disorders. So my question to you, and you may have already heard this answer, but which foundation is responsible for the development of the classification of functional gastrointestinal disorders? So you can have London, A, you can have Venice, C is Paris, D is Rome, or E, perhaps betraying my partisan sensibilities, is Hillsborough. Okay. Is it working? D. Good. I'm seeing someone's put Hillsborough. So yes, it is the Rome Foundation. So what is the Rome Foundation? Well, it's a kind of group of interested gastroenterologists and other sort of scientists, etc. They met in Rome in 1988, and they're perhaps frustrated by sort of the lack of coherence in making a diagnosis of a functional gastrointestinal disorder. Previous classification systems were in existence. The original one was the Manning criteria, and that was in 1978, which then beget the Cruis criteria. But it was only really until the Rome 1 criteria in 1994 that we started to standardise our approach and diagnosis to functional gastrointestinal disorders. So we're now up to Rome 4. They have iterations every sort of 6 years or so. And this was published in last year, so this is pretty much hot off the press. So this is the Rome 4 criteria for irritable bowel syndrome. And what's the diagnosis? Okay. So it's one of recurrent abdominal pain, on average for at least 1 day a week in the last 3 months. And the pain is related to defecation, that it's associated with a change in the frequency of the stool, and also associated with a change in the consistency of the stool. So what we're trying to say here is that the irritable bowel syndrome, it's primarily a disorder of pain. If you don't have pain, then you don't have a diagnosis of irritable bowel syndrome. And what I've put in red is the slight changes that they've made from the Rome 3 criteria. In the Rome 3 criteria, they were talking about abdominal discomfort. Now it's absolutely not that. It's pain, nothing else. They slightly changed the frequency with which a patient was supposed to be experiencing their pain. And the other really important thing for me is that they said related to defecation. So lots of patients opening their bowels, and it's related to defecation. Previously, it was pain that was relieved by defecation. But there is a small cohort of patients who actually, when they open the bowels, they get increased amounts of pain. And so that's been quite a helpful addition. The other thing that the Rome 4 criteria tells us, I think we've lost a slide. We'll crack on. But so what's the value of the Rome 4 criteria? Well, essentially it gives us a nice clinical framework in which we can give a positive diagnosis of someone with irritable bowel syndrome. So the way we used to do it in the old days is that you'd sit down at your computer desk. You'd probably try and fill as many forms in as you wanted to. Send your patients down to endoscopy, do tests, radiological, biochemical, and at the end of that process, you'd have quite a frustrated clinician, and you'd have certainly a frustrated patient. And the diagnosis was always one of exclusion. Well, it's probably IBS. So the Rome 4 criteria is very useful because we can approach our diagnoses and we can treat our patients in a much more affirmative manner. So if the Rome 4 criteria is so good, and if we know that irritable bowel syndrome, every time we do a test, it's always going to come back normal, is there any role for investigations whatsoever? And this is a normal-looking large bowel. And the reason I say that is because a lot of the symptoms in irritable bowel syndrome, there's a lot of overlap between other functional gastrointestinal disorders. So, for instance, someone's constipation, irritable bowel syndrome is another patient's functional constipation, or even one of Dr. Saeed's functional dyspeptics. And the other thing is, even if we look a little bit beyond and look into the world of organic disease, there's a huge minefield of differential diagnoses that the Rome 4 criteria has to navigate through. So, I put it to you then. What test would you order in someone who has a Rome-compliant diagnosis of irritable bowel syndrome? Is it a colonoscopy, celiac serology, thyroid function, carbon hydrogen breath test to look for small bowel bacterial overgrowth? Or is it something called a CCAT study to look for bile acid diarrhea? Okay. So you're absolutely right, it's celiac serology. And how do we know? Well, we have to look to papers like this. This is a slightly old paper, sort of 2002 by William Chay's group. And they took a load of patients that they were confident these patients had irritable bowel syndrome based on a positive symptom diagnosis using the criteria, the prevailing criteria of the time, and that was the Rome 2 criteria. They then subjected those patients to a whole load of tests, and they looked at the pre-test probability to see those patients whether their IBS was indeed something else. And what they found actually, that there was a less than 1% chance that if you had a patient with irritable bowel syndrome or who met the symptom criteria for irritable bowel syndrome actually ended up with a diagnosis of inflammatory bowel disease, colorectal cancer or infectious diarrhea. Conversely, if you had a patient who met the criteria for irritable bowel syndrome, actually the likelihood of celiac disease compared to the general population prevalence was more than 10 times. So what does this mean? It means that if you really need to do a test, all you need to do is do your celiac serology. But you may say, well, fair enough. That's before the advent of doing, these very posh fecal biomarkers. So I'm sure you're all aware of fecal calprotectins. So this is a sort of neutrophil-derived protein which is evolved or secreted from the intestinal cells during times of intense inflammation. So you can see that, for instance, someone who's a control, their levels are going to be normal, whereas someone with active inflammatory bowel disease, they're going to have significantly raised fecal calprotectins. However, this slide is really just to show you that anything can throw off a calprotectin. So if you've got intercurrent bacterial or viral infection, then you'll get a misleadingly positive raised fecal calprotectin. And the other thing that this slide doesn't do is it doesn't tell you about drugs. So just simple things like non-steroidals or PPIs will also increase your calprotectin. So, this is a slightly more difficult question, I think. Which of the following statements is true regarding fecal calprotectin? A. Calprotectin is stable in stool samples for less than 3 days. B. A positive fecal calprotectin can distinguish diverticular disease from inflammatory bowel disease. C. A fecal calprotectin is not increased in patients with constipation. And D. It's appropriate to use fecal calprotectin as a screening test in preschool children. So you've all put A. Okay, well I'll go through them. A is not the right answer. Calprotectin is actually stable at room temperature for up to 7 days, so you can just leave it on the on the kitchen table for a little while if you're that enthused. B, a positive fecal calprotectin can distinguish from diverticular disease and inflammatory bowel disease. No, it can't. It's non-specific. Okay. Diverticular disease anyway is, it's pain associated with diverticulosis. So really, you'd expect to raise fecal calprotectin if you've got an episode of diverticulitis. C, fecal calprotectin is not increased in patients with constipation. Well, that's absolutely the right answer. And the final one, quite a difficult one actually. Just be mindful that in your paediatric population, the normal values are approximate to adult values for IBD. So if you see a raised calprotectin in a child, the last thing you want to do is send them for a colonoscopy.
So can I ask, is it more like an ESR or a CRP?
Well, it's just a marker of inflammation, so shedding of these neutrophil-derived proteins from the gut. So it's helpful for, say, inflammatory bowel disease because it will instigate the process of diagnosis. But it's also useful in, for instance, assessing response to treatment and also assessing potential relapse of a patient. But it is a non-specific test.
So when you said it was high for viral-related gastroenteritis, by when would it settle down if it had been raised because of that?
I'm not sure of the half-life of these sorts of things, but essentially when that period of infection has abated, then your calprotectin levels will return to normal, providing this isn't a superadded infection on established, GI disease. And, if we look at other papers, this is quite a nice study in 2015. And essentially this looked at the various biomarkers that we have that tried to distinguish between inflammatory bowel disease and irritable bowel syndrome. And after looking at their meta-analysis of 140 different papers, they said that, if you've got a CRP of less than 0.5, or if your calprotectin is less than 40, then you've pretty much excluded inflammatory bowel disease. And certainly less than 1% of positive diagnosis will come through there. So you can then start to think, well, if I've got, the Rome 4 criteria, if I've got simple tests like a CRP and a calprotectin, if I've got a patient who doesn't have any red flag symptoms, then actually this is probably irritable bowel syndrome. When patients come to secondary care or to tertiary care, there's always this fairly awkward sort of dynamic between the clinician and the patient. Usually patients bring a lot of expectation about their diagnosis, the course of investigation, or their management. And, sometimes you think, well, should I just send off for a quick colonoscopy? If it's normal, I can then discharge her back to primary care. And yet, if we look at papers like this is a paper that says that looked at, well, actually, is it reassuring to offer someone a colonoscopy if it comes back negative? And they actually concluded, and what they concluded that if you had a negative colonoscopy with your irritable bowel syndrome, it didn't offer any improvement whatsoever in terms of your health-related quality of life. So even giving them a negative colonoscopy, they're going to be frustrated by that. So, back to my patient. This is still the first consultation with her. I suggested that there was diagnostic uncertainty. And I also said, fairly gently, I don't think this is inflammatory bowel disease. And yet my diagnosis was actually one of diarrhea predominant irritable bowel syndrome, with probably an exacerbating effect from her recent Campylobacter infection. So I stopped to 5 ASAs. I felt in some way compelled to reinvestigate her, simply because she was absolutely convinced she had inflammatory bowel disease. With these sorts of patients, what we like to do is not only do a colonoscopy, but we also like to do a terminal ileoscopy, so get into the small bowel. And so I proposed a repeat endoscopy, repeat blood tests and fecal calprotectin, but I stressed that the expectation was that these tests were going to be normal, and I think that's very, very important. So, investigations, everything normal, okay. Stool cultures, calprotectin less than 8. And her colonoscopy, including TI intubation, was normal. So, what did I do? I started on some simple antispasmodics. I then made a referral to our dietetic department, and as Monica is going to show you shortly, dietetic therapy has a huge role to play in irritable bowel syndrome. And I also do this kind of preliminary discussion or exposition with the patients about whether we should start thinking about a tricyclic antidepressant. And if you ever go to any of these sort of hardcore gastroenterology conferences, they always talk about the brain-gut axis. They talk about this interplay between, the psyche, peripheral hypersensitivity, visceral dysmotility, and then they start wheeling out the big guns like mucosal permeability and alterations in gut microbiota. At that point, you've kind of lost half your audience. So I just keep things very simple. This is what I always draw for my patients in clinic. This is particularly looking at tricyclics. And I explain that, the gut and the brain have a healthy relationship in normal people, and we have the fecal stream going through the large bowel. I then say that, and I stress the sort of visceral hypersensitivity part of it, I say that, lots of these little sort of nerve fibres in the gut are completely overloading, the normal pain pathways. And this is being represented as abdominal pain, as discomfort, as changes in their bowel habit. And I say that, rather than, sort of just proceeding down, sort of simple or first-line approaches to irritable bowel syndrome, sometimes we have to sort of down-regulate this mechanism on drugs such as tricyclic antidepressants, in particular amitriptyline. Amitriptyline has the biggest evidence base for this sort of thing, is entirely the thing that we should be doing. I'll never give anyone amitriptyline on their first consultation, and we always only ever use it at very low doses, so I start at 10 milligrams nocte for 4 weeks and then increase up to 20 milligrams, and at that point I pretty much leave it. But it can have a very beneficial effect on patients. And it also can have a very beneficial effect on, the side effects of amitriptyline are very useful. It's constipatory. So, for instance, if you have someone who's got diarrhea predominant irritable bowel syndrome, then you can use it with good effect. Rome 4 also teaches about how we can subtype our patients. So, for instance, we can classify someone according to whether they've got diarrhea predominance, constipation predominance, or a mixed subtype. And the reason for doing that is it doesn't really tell us too much. I mean, essentially, irritable bowel syndrome is like an umbrella term for a very heterogeneous population of people. But really, it gives us some sort of idea about how we should be treating our patients. And this talk is not really aimed at talking about therapy. Well, certainly Monica's going to be talking about the dietetic part of it. But really, if you've got someone with, say, diarrhea predominance, think about your first-line agents such as loperamide. Or conversely, if it's pain, you'd be thinking about linaclotide or those sorts of agents. So we can use the IBS subtyping in that manner. But really, the most important way to treat a patient is to educate them. So they always get this leaflet from me. So this is the Gut Trust, which then became the IBS Network. It's about a 4-page document. I point them to the IBS Network, And I implore them to go and, to educate themselves on this condition. It's recently gone behind a paywall, but I think it's only about £20 a year or something like that, and it offers so much help and helpful advice. So in summary, what we need to be doing is, primary care physicians and in secondary care is striving towards a positive diagnosis for our patients with irritable bowel syndrome. The doctor-patient relationship is absolutely key. And I'd suggest to you also that, this is a chronic relapsing remitting disorder. The quality of life of people with irritable bowel syndrome can be as afflicted or even more so than anyone with organic disease. So making sure that, for instance, the patient sees the same doctor every time. They need to be reassured, they need to be educated. And if you're going to propose investigations, they need to be limited, they need to be timely, and they need to be non-invasive in the first instance. Always with this caveat that you entirely expect that these tests are going to come back normal. And finally, you need to be fairly realistic with your patients as well. Last thing to say, Sabir was very prescient in asking for an IBS talk when it's IBS Awareness Month, and that's all I have to say. Thank you.
Time for just a few questions before we start with Monica's talk on the diet side of IBS. Anyone?
Celiac disease, can it present at any age?
Celiac can present at any age, absolutely. But there may be a patient presenting with symptoms, but then again, it may be a knockout presentation where you notice that, for instance, they're iron deficiency anemia or anemic, or they've got suggestions of malabsorption on their blood tests.
Right. It is an autoimmune process. So I have patients who is 2-year-old. Then yesterday, I had a patient who is 21 years old. So all this time, was it not reactive or?
Well, there's always that. There's a lot of patients with celiac disease who haven't been diagnosed because we haven't done the tests, and I'm sure there's a lot of patients who, there's a kind of progression in their autoimmunity where they become sort of later presenters. So.
Can I ask here who regularly requests fecal calprotectin tests? A few. For the rest of us, can you tell us how we order that fecal calprotectin?
Just purely on a practical level, it's available on ice. So just put in Calpro, and it will come up, and you tick the box, and out will come. It will print out the
blue bottle.
It's just your normal sample bottle.
Under biochem.
Yeah, and then you invite them to go home and fill it up at their leisure and return it to wherever.
Any other questions? No. Thank you, Dr. Bullas. Let's have Monica from London to tell us about the diet side.
Just what I will say, as Monica's approaching the, I don't know what that thing's called, but the table, but Monica has very kindly agreed to come all the way from London. She's a very senior dietitian and works at St George's, and she's been doing pure gastroenterology for the last 3 years. We're desperate to try and get her up to Barnsley because what we'd very much like to do is set up our own IBS clinic. There's a couple of our gastroenterology consultants, including myself, who have an interest in functional bowel disorders. We've recently appointed a non-medical nurse endoscopist whose hobby is to do hypnotherapy. And hypnotherapy, for those who aren't aware, is a beautiful treatment for someone who's got refractory irritable bowel syndrome. But dietetic treatment, as Monica will allude to, is the hallmark of treatment in IBS, certainly in the diarrhea predominant patients.